I don't have any potential conflict to disclose for this topic. As you all know, venous system is a network of interconnected vessels, and any preserved inflow of the saphenofemoral junction may be the cause of the recurrence of varicose veins. And the main causes of this inflow may be the long stump of the great saphenous vein or the parallel vessels that ends in such a region. Anterior saphenous vein may be one of the important causes of recurrence, and in addition, it bothers the patient very much because it's meandering position along the leg. And as we discussed, the causes of the axial reflux at the saphenofemoral region, we have 4 types of this axial reflux, and we will find that anterior accessory vein represented more than 10% of this reflux at this region. So if we can deal with this 10%, we can minimize, of course, the recurrence of these varices. We have to know what are the most important variations of the saphenofemoral junction and how the anterior accessory vein ends. This is the most common type when it joins the saphenous vein and ends at the region between the terminal and the pre-terminal valve. This is the main type and represents more than 40%. We have other 5 types also ends at the region related to the saphenofemoral junction with different terminations and different flow. Either it comes from the pelvic or from crossing veins. This makes it is 6 types that ends at the saphenous vein. And this is a rare 2 types. The upper one where it ends by opening, separate opening at the femoral vein, and the other one when the axial reflux came from upward. This is the ascending theory. So if we ablate the anterior accessory vein, we can be sure that we have at least more than 90% of the recurrence at this saphenous region. This was the hypothesis of our series, and the objective of our trial was to compare the standard endovascular laser ablation, 1.5 to 2 centimeters from the saphenofemoral junction, to ablation of the great saphenous vein at the 0 point, exactly at the saphenofemoral junction. We have 80 patients admitted to the Royal Vascular Center from January 1st, 2022 to December 30, 2022, divided into groups. Group A treated by ablation of the great saphenous vein at the saphenofemoral at 2 centimeters from the saphenofemoral junction, and the other group, 40 patients treated by ablation of the great saphenous vein at the 0 point crossectomy at the exact junction between the saphenous and the femoral vein. This is our instrument. This is the Cerealis pyrolytic machine, and this is the radial fibers that we used in our technique. And as you see, this is the laser applied at the saphenofemoral junction at the 0 point, and as you see, there is no propagation of the thermal wave to the femoral vein. You see the duplex, the thermal ends at the exact point at the saphenofemoral junction does not extend to the femoral vein. The demography of our results, as you see, our age about 34.6, and the male to female ratio in both groups was about 14:6 and 12:8. As you see, the body mass index in our series about 31. We have 30% of our patients were smokers, and the procedure done in 80 persons. And the side affected more on the left side, more than 60%. And as you noticed, the unsightness was not the main complaint of our patients. The main complaint was heaviness and dilated veins. Of course, edema represents 60% of the patient, and unsightness represents about 65% of our group. As you see, the main of our patients lies in C3 and 4. And the vessel diameter was about 0.95 and 0.96 in group A and B. No significant difference between patients in both groups. And after procedure, there was a significant reduction of the thigh and the leg diameter in both techniques. The post-operative pain, there was no significant difference between pain in both groups, either immediate post-operative or 7 days after the procedure. This is very important. As you see, there's significant reduction of the VCSS in both groups, significantly in either standard or the crossectomy patients. Again, we have about 5% of our patients return to their work after just 1 day, but the main group returned to their work about 60% after 2 days, and the rest of patients return to their work after 3 days. No more than 3 days, they have to stay out of work. This is the duplex post-operative duplex after immediate post-operatively ablation of reflux in all patients, and 1 week later, not the reflux in both groups. But this is very nice after 1 week, 6 months, 1 year, and 6 years. As you see, we have only 1 patient of recurrence of reflux after 2 years in cross-sectional patient, but we have 6 patients of reflux after for the standard technique. When you study the causes for this recurrent in standard technique, we found that this is the cause of recurrence. We have 1 patient due to neovascularization, 2 for incompetent tributaries, and 1 for incompetent anterior accessory vein, and recanalization shown in only 1 patient, while we have only recanalized 1 vein in the crossectomy procedure. This is the neovascularization. It is shown on the duplex. We don't have major complications rather than superficial thrombophlebitis and the recurrence, of course. To conclude, Mr. Chairman, crossectomy ablation at the 0 point from the saphenous junction showed better results with less recurrence of the varicose veins due to neovascularization or tributaries left, and then the standard technique of the endovascular laser ablation of varicose veins, and won't allow thermal propagation of the deep venous system nor venous thrombosis without increase in the complications rate. Before I go, I would like to invite you all to Egypt to join our 12th international conference in Domyat and Port Fouad, and it is the first international vascular congress that will be held in 2 continents. 1 day will be in Africa, in Domyat, and the other day will be in Port Fouad in Asia. This is the first Afro-Asian conference. Thank you, and